People have said to me, why do we need surgeons anymore in melanoma? We have such amazing drugs. Aren't you out of a job? I'm here to tell you, maybe not. So let me give you a history lesson. This is the bad old days of surgery for melanoma. So these are patients that are still alive today. When I was an intern, which is my first year out of medical school, my first clinical attachment was actually at the melanoma unit at RPA. So I saw patients who had wide excisions for primary treatment of their melanoma, and they were wide excisions, 3 to 4 centimetres wide. You needed a skin graft to actually close the skin together. And the patient on the right had what we call a therapeutic dissection, or all their lymph nodes were removed, because even though there appeared to be no disease there, because it was just thought you had to have aggressive surgery to cure this disease of melanoma. And in fact, that patient on the right who had a groin dissection is my patient now. He's number 233 in our database of over 50,000 patients. He's still alive today, possibly because of the surgery, but possibly maybe because his immune system is much better than anything else that we can give him. So I'm here to say to you that surgery for primary melanoma is still curative. If you have a thin melanoma, which is 70% of patients, a wide excision will still get rid of the melanoma. So what we call melanoma in situ, the thinnest melanoma you can get in the top layer of skin, and also thin melanomas, a wide excision is curative. However, if you have an intermediate thickness melanoma or a thick melanoma, which is greater than 4 millimetres in thickness, you probably need something else as well as a wide excision. So Richard's talked about the lymph nodes, and when we look at a primary melanoma, we need to assess whether they have spread if they are riskier melanomas. So usually the intermediate thickness ones or the thin ones that have adverse features. And Richard's already told us what a sentinel node biopsy is, but I'm going to give you a little bit of detail so that you can see what we do. So the nuclear medicine scan injects a radioactive dye at the primary site, and the picture on the left is actually the first 10 minutes of the scan. So the blob, big blob, is where the primary is, and even at the first minute, you can see a channel of dye to that first lymph node. So the picture on the right is 3 hours later, and it's very obvious that there's a single sentinel node for this particular primary melanoma. So primary on the elbow, axillary sentinel node. Then during the operation, I inject blue dye, patent blue dye, similar to what the nuclear medicine people do, around the primary site. And the nuclear medicine people actually make it very easy for surgeons. Surgeons are very simple beings. There's an X that marks the spot, so we just cut there, and we find the lovely sentinel node. So we make sure that it's the sentinel node with a gamma probe. So it's a radioactive probe, so it squeals when we actually point it to the sentinel node, and also the sentinel node is blue. So you can see that on the picture on the right. So once we've removed that, Richard, of course, does his thing. If the sentinel node is negative, then routine checkups. You don't need any scans usually, you don't need any drug therapy, you do need regular skin checks. However, if the lymph node is positive, we used to actually take out the rest of the lymph nodes in that area. And that really happened up to about 2 years ago. But one of the trials that our unit had participated in, and it was a worldwide trial, has shown that you don't need to take the rest of the lymph nodes out. Yes, there's a 20% chance that there are other lymph nodes in that area, but there's no survival benefit. So the trials that we're doing have actually changed practice. The trials that our unit has participated in has actually changed practice. So we don't have the complications of significant lymphedema for these patients who are sentinel node positive. And with the drug trials, as Richard had said, The drugs actually improve survival. So what about nodal disease? So the picture on the right is actually a lady's groin and she's got a lump in it. If you have melanoma and you develop a lump, you can feel a lump somewhere, don't wait. Go to your doctor, have a look, get them to have a look at it. And they will probably need to organise an ultrasound and a needle test to suck out some cells to find out whether it's melanoma or not. And if it is, we have to make sure that it is nowhere else. So we will organise a PET scan and also a brain scan. Just a little explanation of why we need both. PET scans are great for diagnosing melanoma, a lump of melanoma somewhere, but not so great at looking at it in the brain because the PET scan will only show something that is about 1 centimetre in size. So you need a separate brain scan, either an MRI brain or a CT scan of your brain to work out if there's smaller metastases of melanoma. Then the recommended treatment is actually to take out all of the lymph nodes in that area and then have extra drug therapy to reduce the risk of it coming back. However, we have new trials now and our unit, Georgina in particular, has been a great advocate for these combination trials, combining surgery and drug therapy in novel ways. So we are using neoadjuvant drug. What that means is giving drug before surgery to try and shrink the tumour, and then we've got a trial currently, just take out an involved node or the involved node to see if the drug has actually worked. If it has, the patient doesn't need a dissection and may not even need further drug therapy. So it's an exciting trial. Minimise surgery, hopefully minimise the complications from surgery. It's still a trial, so don't go out there and say this is the treatment that everyone needs, okay? It's the trial. So we got to work out whether it's safe or not. And that's the beauty and the joy of working at a place like this. We're pushing boundaries. We're actually trying to, I guess, reduce the morbidity of the treatments that we undertake or ask you to undertake, but hopefully improve survival as well. This is a special type of, I guess, recurrent melanoma called in-transit disease. And it's actually recurrent melanoma that appears between the primary site and your lymph node field. So it usually appears on the skin or just underneath the skin. And we can use different treatments for it. Simple excision, so surgeons have a role there. Diphencyprine cream, so it's a cream that actually stimulates the immune system, so it's not for bulky stuff like this, but I guess like measles or chickenpox. Injectable agents, they're not readily available in Australia, unfortunately, so if someone wants to advocate for it, that would be great. We'd love to use it. But if it is extensive, we use this thing called isolated limb infusion, which was actually invented by Professor Thompson, who was one of the surgeons and the founding fathers of Melanoma Institute Australia, and of course systemic therapy. I'm going to talk a little bit about isolated limb infusion. So basically, what we're doing is giving people's limbs, arms or legs, chemotherapy and just isolated to that limb with a tourniquet. So we put chemotherapy in, take it out through the vein, and the drug only affects that limb. And it's reasonably successful, about 40% response rate. So it's pretty impressive. Everyone thought that this would go out of fashion with the new drugs. It hasn't. So the people who are failing drugs, who are actually, I guess, not responding to drugs, we're actually starting to use these techniques to treat them as well. Systemic disease, surgeons still have a role, and so the scan on the right is actually a bowel metastasis. So if that grows bigger, it can bleed, it can block the bowel. So we actually have a role in removing that so that people can live another day to fight and get drugs. The scan on the right is a brain metastasis, so if you have a seizure, if you are symptomatic from that brain metastasis, you probably need it out before getting drugs. So surgery has a role in many places. And I think it really is a new era of collaboration between specialist clinicians who treat melanoma. So the drug clinicians, surgeons, radiotherapists, and also the trials that we have. So we truly believe that if we can put a patient on a clinical trial, that's actually a good thing. We have a robust discussions every Friday morning. As Richard has said, 7 a.m. is pretty early, but we always come willingly because we're always learning new things. I learn a new thing at least once, once every meeting. And it truly is a robust discussion between clinicians. We actually advocate for different treatments and we fight. And we say, well, what about this? What about that? And that's, I think, to your benefit, patient's benefit. Because if we as clinicians can actually argue it out and say, well, we think this is the best pathway for you, then, and it's a specialist discussion, I think you can do no better. So, new era of melanoma treatment, collaboration. So surgery is not always the main treatment anymore. We really need to collaborate with our clinician colleagues. Thank you.